Good morning. Good morning everywhere in the world. I'm going to talk to you about lymphatic filariasis, and some of the data that I'll give you will be data from our group in Liverpool, so I just want to acknowledge them in the start. So what's happened in the last 25, 27 years, at least in parasitic diseases, is a major shift with treatment. And it was started by onchocerciasis control program that David talked about. It was started with Merck and MDP. It then moved to the lymphatic filariasis program that GSK headed. And now we have other NTDs. And this major shift in treatment is something that I want to focus on and see if we can't keep it going, and hope that, certainly in terms of patient care, that we can use this initiative that started actually 27 years ago to try and continue getting care for all, and particularly addressing things like the sustainable development goals. One of the points about these diseases are that, unlike malaria and others, they're not killing diseases but chronic diseases. And I'm obviously focusing on chronic disabling diseases in this talk. Who are lymphatic filariasis patients? They're obviously the reason we have the lymphatic filariasis program. If we didn't have patients, we wouldn't have the program. It is a very chronic and obviously disabling condition, and the patients are very central. We've tended to not work on them so much or work with them in the last 10 or 15 years from the beginning, and we're doing it more now. They are important in advocacy. People don't necessarily take the drugs unless you see you're doing something for the people that actually have the infection or have the disease. And they really are important in success, because success would be that there are no new cases. They are a classic example in lymphatic filariasis of a chronic disabling disease, of which there are others that in the NTT group, and particularly podoconiosis and leprosy, as two somewhat similar patient care issues. Establishing a long-term care for people who are affected by lymphatic filariasis is really, I think, the ultimate success, because a lot of these patients will still need care after we've got rid of the parasite, we've got rid of the cause. And these people do live in some of the most underserved parts of the world. So really, can we use what we're doing for lymphatic filariasis patients to help serving all of the disabled people? What is actually going on inside a patient, just for those that are not familiar? Essentially what's happening where the parasite is lying in the lymphatic vessel, the lymphatic vessel actually grows. It doesn't really block. And what happens is that you actually get a much more dilated vessel, not a blocked vessel. And it's that dilated vessel which is unable to pump fluid away from the tissues and clean the fluid away. So it's actually a growth, not a blockage. At the tissue level, you get lymphatic stasis and inflammation. That results in, obviously, the tissues that it should be draining the fluid away from, degenerating, dermal degeneration. And in many patients, it reaches an irreversible point in the pathogenesis. And those patients are never going to recover back to normal. And they're, of course, the chronic disabling people that we're talking about here. Then there is the changes in the quality of life, stigma. The acute attacks that accompany this are actually the thing the patients really dislike. Quality of life, and I would say family life in particular, is also destroyed. Economic hardship and mental depression that comes with that. What is the global program? Just to fill you in on that, the aims of the lymphatic filariasis program was to eliminate it as a public health problem through really two approaches: interrupting transmission by the drugs and then managing morbidity. I would point out that it differs from onchocerciasis because the treatment in onchocerciasis is actually the same as the treatment of the patients. So by breaking transmission in onchocerciasis, you actually get rid of the disease. That is not the case with lymphatic filariasis, at least a majority of the chronic disabled patients. The other point I'd make here is that, in fact, everybody who is infected with lymphatic filariasis does have some change in their lymphatics. It's not as though they have nothing going on. Even children at the age of 4 do have changes in their lymphatics, which can be reversed if you remove the worm. The global program is essentially one that has these two arms: mapping, first phase, giving the drug, and then assessing that the parasite is gone, and with the patient care side, the morbidity management side, obviously developing a program and then keeping it going, and then the successful verification by WHO. So that's what the global program is. Usually it's 5 rounds, at least that's the theory. We have gone to many more rounds in other countries. TAS is just the transmission assessment survey, and of course there are other monitoring activities along the way. So let me just turn to what is success. And if we look at what has happened to date, we've got, at the inception of the program around 2000, there were predicted to be 120 million people at risk, with possibly 40 million suffering, maybe more. After 8 years, and this is all data that was released a couple of weeks ago by WHO, after 8 years, it saved probably $24 billion was saved by actually reducing the number of cases. So after 13 years, there have been 100 million cases prevented, and that's the prediction, with probably 36 million cases remaining. Although the number of cases is really still something that is still a bit of a guesstimate. In 2014, again, there was on the global area, the global approach, there was 73 countries endemic, 18 had reached that TAS stage. In other words, they were looking at stopping treatment. 55 still had treatment going on, and there are 11 that had not yet begun MDA in 2014. 21 of these 73 countries actually had 100% coverage, meaning all the endemic areas were really getting treatment. That means in 2014, 5.62 billion people were treated at least once, and obviously one of the biggest chemotherapeutic approaches ever succeeded. Attempted and succeeded, with still more to come. Some of the challenges that were also identified in the WHO article were still a perception of a low burden, in other words, a low disease level, a lack of prioritization in ministry agendas, in countries, in health agendas. It's not a killing disease. And the consequent lack of domestic investment. And one prediction is that at least the next 5 years of continuing the program would need about $154 million US. So what kind of success can one see? I've mentioned 100% geographic coverage, and these are points at which countries can actually celebrate success, and I think that's very important, to have countries actually get to some point and actually be able to say, yep, we reached that point. So 100% geographic coverage is one good point to reach, and some countries haven't even started. The stopping of MDA treatments, obviously stopping of treatment is a big plus. And then the successful submission of the WHO dossier and the actual validifying by WHO team of having actually succeeded in preventing that public health program. The one that I add now is integration of the chronic patient care into the health system. And I think that's almost the biggest challenge we have. And of course, I still like no new cases, and that's something of long-term surveillance. And how long that term is, I think, is something that still needs to be discussed. Give you a couple of examples from our program in Liverpool. Here's an example of 100% geographic coverage in Mozambique. And Mozambique was a country that a few years ago was regarded as a challenge to get things going. And you can see here over on the other side there, 2009 in red, there was only geographic coverage in a few of the pink areas, which are the endemic areas. The yellowish area is non-endemic. And by 2014, we have complete coverage of the whole country. That's a success point for a country, and a big country. Another one here in stopping treatment, here in Bangladesh, which is a very positive program. You can see in red on the other side, there are the endemic areas that have got all 100% geographic coverage. And in here, over this side, the red is the one that's still remaining and hasn't stopped treatment. So the blue areas and the green areas have at least passed one of the stopping treatment tests. So that's rapidly going towards success, and I believe we'll be very successful soon. I mention this because this is an important step, and this is the WHO dossier, which is really the submission to WHO that they have fulfilled the requirements of reducing their infection levels to a level that is acceptable to WHO consultantship group. What's important about this is that that there is an inclusion of a patient care need in this, and that the patient care, part 2 of the team, of the requirements, are involved in this dossier. And this actually gave countries something to aim for in terms of their morbidity care program. Before that, it was rather vague, and we weren't able to tell countries what to aim for. They needed a goal, a simple goal. This dossier goal has, which doesn't have two really very difficult things to do. They need to know how many patients they have, and they need to have care available to those patients and accessible to those patients. If they do that, then they are likely to fulfill the dossier needs. That really catalyzed in our programs a country to know where to go. And I think it's something that perhaps other chronic disabling diseases could mimic. So long-term success, really, just to repeat that long-term success to me is really after you've got rid of obvious things like the hydrocelectomy surgeries, which one can really go ahead and get rid of the backlog, like with trichiasis, but embedding of the provision of care into that health system of each country, and that's the most difficult thing. And that is one that I think fits into the goals of universal health coverage. And if we can use lymphatic filariasis and other chronic disabling diseases to do that, then I think we will have really pushed this a long way. So if I look at the way the programs have gone, we talked about onchocerciasis, and David mentioned all of these. The onchocerciasis program came in, lymphatic filariasis came in, and patient care is something we needed to emphasize and are doing more now. There are other NTDs that have come in and just call this the NTD era, with either chemotherapy, environmental change, direct treatment, and other approaches. And then what I'd like to see that we have is a continuing care phase of universal care. And hopefully that will be when we really are successful as a group of eliminating diseased people. So what can you do to get it to this next phase? Integrating it into the health system needs training, needs all of the things that Virginia talked about. I just want to emphasize healthcare workers because I think they're very key to this. They're active in the MDA programs for us. They know the patients and they actually can select the patients for care, and we need to empower them. And how do we empower them? Just to give you one example that we've been moving towards in Liverpool, and that is actually using mobile phone technology, and we've been using it to identify patients, management of supplies, so they can request supplies. And actually, we haven't quite got here yet, but we want to also use at least smartphones to be able to give them up-to-date information and so they know what to do. And this is work that's come out of Louise Kelly-Hope and Michelle Stanton in our group. And this, just a couple of images of this taking place in Tanzania, where we've trained people in using these phones, SMS first. Interestingly, a lot of the healthcare workers couldn't actually send text before. They now can, so we've empowered them there. You can get this is actually a study that was done in Dar es Salaam, where you can see over time, you get a real-time reflection of the cases that we've been following over, you can see in the graph up there, and you get a tabulated form. So what we've used this for is actually looking at Dar es Salaam to see where the patients were. And Dar es Salaam has about 5 million people, and we did a house-to-house survey there. We used 300 health workers, and we came up with just under 7,000 patients were identified using the SMS system. This Dar es Salaam is quite a challenge, as many of you that know Tanzania would know. That now allows us to focus where to put hydrocele operation centres. See here the camps on this side, or at least where to focus patient care. So this sort of technology has been very useful. We also, as I said, use it for ordering things if they need to move drugs around or to order soaps. And so it's a way of empowering the health worker. That way we get much more universal health care. The last piece I just mentioned is really integration with other NTDs. And this strengthens the healthcare worker's ability to actually serve her or his people. Lots of ways of training together, and this point's been made by Virginia about getting people together. And the mutual integration of these into the national health system is where hopefully we can go with this. So collaboration across, we have programs in Liverpool in leprosy programs in Nepal and Mozambique, and in Ethiopia with the podoconiosis group that Gail Davies works with. And I say there we're mutually appropriate. I think integrating where it actually is inhibition is not a good thing, and I'm sure we can find enough things to do together. We've mentioned the NNN group. That's an important global group to be part of. And just to give you a heads up, the term disease management, disability and inclusion is one that has been requested as a new name, which we're submitting to WHO to see if that's acceptable. So MMDP, you might soon see as DMDI, and it's not DNDI, as many of you know. So really, NNN group is a very important group in terms of getting us together for chronic disabling conditions. So the challenge is to integrate, develop the country support system. I think that's very difficult, but needs to be done, the policy part. Defining care, the science part of our title here, that's still something we can do. And the political will is absolutely essential, and advocacy and politicians are always central to any of these programs. And then move together, we must put efforts in these areas. So I will end by saying that I think LF Care, as we move forward, is an opportunity to move to these goals of universal health care, the Sustainable Development Goals, and just general strengthening of what's going on. Lymphatic filariasis does affect both genders, even though obviously hydrocele is somewhat biased in one group, and it does affect the young. And as I said, the young do have pathology. So in summary, just to repeat what I've said, this first onchocerciasis program sort of moved us through to the second program, which was different. It was something, originally we were based on NGOs. We focused more in the second phase with lymphatic filariasis on ministries of health, and in the new phase we can say, seize the chance to bring care to those people who do have disabling conditions. And so patients really are central for long-term future of chronic. That's an obvious statement, but sometimes we tend to forget it. And I just acknowledge many people who are part of what we're putting together in Liverpool, and particularly the group in the filariasis program support centre, and the ministries of health in Tanzania, Bangladesh, and I should have added Mozambique there. Thank you.